In this particular section, we are going to discuss in detail about the plasma cell dyscrasias. Plasma cell dyscrasias is going to be a huge topic, and just pay attention and be a little bit patient as well. So number one, you have a lot of types of plasma cell dyscrasias. The first one is the typical and the godfather of all the plasma cell dyscrasias, that is multiple myeloma. That is multiple myeloma along with its variants. Multiple myeloma and its variants. What are the variants of multiple myeloma? You have something called a non-secretory myeloma. Second one, you have something called an asymptomatic or a smoldering myeloma. All of these things we are going to discuss, so no hurry right now. Then you have something called a plasmacytoma, which just called as a solitary plasmacytoma most of the times. Then you have something called a plasma cell leukemia. Plasma cell leukemia. There will be a lot of differences between them, but everything will come under the multiple myeloma and its variants of multiple myeloma. Clear? Second plasma cell dyscrasia is very important noise, that is called MGUS, that is called monoclonal gammopathy of undetermined, uncertain, unknown significance. You can call it anything. MGUS or MGUS. Third one, you have something called a Waldenstrom's macroglobulinemia. This is called a Waldenstrom's macroglobulinemia. Fourth one, you have something called an immunoglobulin heavy chain deposition disease. That's called IgH deposition disease, or you have three types in that: alpha, mu, and gamma heavy chain deposition disease, but we'll discuss anyway after some time. Finally, you have something called a POEMS syndrome. POEMS is also very important, which I will again discuss later on. And again, this is the only area where you see osteosclerotic myeloma. You don't see an osteolytic myeloma. Usually, lytic lesions are common in multiple myeloma, but in this case, you're going to see an osteosclerotic. In that way, that POEMS syndrome is also very important. But anyways, these are the various plasma cell dyscrasias. So once you have known about the plasma dyscrasias, let us discuss the, as I told you, the godfather of the plasma cell dyscrasias, that is the multiple myeloma. Remember, what do you mean by multiple myeloma? It is nothing but, definition wise, if you see, it is again a clonal, I'm writing monoclonal here, but it's a clonal proliferation or neoplasm of plasma cells. Clonal neoplasm of plasma cells. Clear? What are these plasma cells? These plasma cells are nothing but post-germinal center B cells that are activated and differentiated into a different group of cell called plasma cell. So if you want to localize where it is originating from, because why it is important, because to avoid confusion, you have this germinal center, here you have this proliferating lymphoblast or centroblast, we call it as, simply you can call it as just proliferating lymphocytes here, germinal center lymphocytes, which can be either go for apoptosis because they are not selected for the future, or they can be selected for differentiation and further movement into the other lineages. So selected cells either become a memory B cell, or either they're going to become a plasmablast. These plasmablasts are the ones that are going to differentiate into something called a plasma cell. You have to be very, very sure that this is a malignancy of plasma cell and not a plasmablast. Clear? Remember, one example of a plasmablast producing a tumor, your ABC type of DLBCL. We discussed already about this. Your activated B cell type of DLBCL is originating from the plasmablast, not multiple myeloma. It is multiple myeloma is originating from the plasma cells. It's a plasma cell neoplasm. Typically, remember, these plasma cells are going to secrete immunoglobulins. It's a neoplasm. And that is the reason why they also secrete excessive amounts of immunoglobulins in multiple myeloma, even though it's not functional. Since these are monoclonal plasma cell neoplasm, the immunoglobulins that are secreted are also going to be what? Monoclonal immunoglobulins. Clear? A single type of immunoglobulin. That's what they're going to secrete. Remember, even though we call these immunoglobulins are secreted in excessive amounts, I can surely tell this immunoglobulin that are secreted are dysfunctional because they are coming from malignant plasma cells. They are not going to secrete a proper immunoglobulin also. So which means these patients are also going to have increased risk of infections. number one. And not only increased risk of infection, this increased immunoglobulins is also going to result in amyloidosis. That is because of something called AL, amyloid light chain, AL type of amyloidosis. They can also cause something called light chain deposition in multiple areas, and they can result in problems like kidney disease. That's also called as light chain deposition disease, LCDD. They can also result in something called a coagulopathy, and they can also result in something called a neuropathy. They can also cause something called a neuropathy. If you ask me why coagulopathy, remember, coagulopathy is typically due to this amyloid light chains only. Once you get this amyloid light chains, they are going to bind with factor 10 and they are going to reduce the levels of active factor 10. That is what is important. So which means reduced levels of active factor 10 will be low because of the binding of the AL amyloid with factor 10 reducing. That is the reason why they get coagulopathy. And neuropathy, typically what they get due to excessive immunoglobulins is going to be demyelinating type of neuropathy, which is very common for even neurology, topic to understand. And one more interesting point is, I told you these plasma cells are long-lived plasma cells. The plasma cells that are coming through this class switching and all this selection process is going to be a long-lived plasma cell. I told you any long-lived plasma cell will migrate back to the bone marrow and they are not going to be seen in the lymph node, which means these neoplastic plasma cells are going to be in the bone marrow, not in the lymph node. That is the reason why multiple myeloma patients do not have significant lymphadenopathy. Very, very important. It's one of the important defining and differentiating features, especially to differentiate from a Waldenstrom's macroglobulinemia, sometimes which might simulate a multiple myeloma. Clear? So very important. The long-lived plasma cells are going to migrate back to the bone marrow. Since this is a tumor of the long-lived plasma cells, you are going to have a neoplastic collection in the bone marrow, not in the lymph nodes. Do you understand? Yes. So this is what the most important point about multiple myeloma is. And very importantly, I told you these are post-germinal center plasma cells, and these post-germinal center plasma cells are under the strong influence of some important factor called NF-kappa B, nuclear factor for kappa B, because this is the very important survival factor for this post-germinal center cells. Remember, within the germinal center, the most important, these germinal center cells, very important is BCL6. We know that. The cells that are selected, very important is this plasmablasts that are selected, and all these things are very important is BCL2. But for plasma cells, you need this NF-kappa B. This NF-kappa B is a very, 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 very important, growth factor for survival and proliferation of this plasma cells. Similarly, this NF-kappa B is also a very, very, very powerful stimulator of your immunoglobulin production within the plasma cell. So there should be a way where this NF-kappa B is produced in excessive amounts within the plasma cell. How? A lot of mutations have been described, but one way where this myeloma cells upregulate this NF-kappa B within their own cell is, you have naturally one important component in the cell that's called a proteasome, very important component. So usually this NF-kappa B will also be in conjunction with something called an I-kappa B. That's called inhibitor of kappa B, that's called I-kappa B, and they are produced separately. And once they join with NF-kappa B, this NF-kappa B will be degraded. Clear? So what this multiple myeloma cells are going to do is, they are going to take this I-kappa B into the proteasome, I-kappa B into the proteasome, and they are going to break down this I-kappa B, and they are going to reduce the levels of I-kappa B, which means multiple myeloma cells or myeloma cells can do this only by activating the proteasome. That is the reason why two things are there. In multiple myeloma cells, the proteasomes will be very active, number one, that is to down-regulate the I-kappa B, that is inhibitor of kappa B levels, and to up-regulate the NF-kappa B levels, which is very important for survival and proliferation of these neoplastic plasma cells. That is also one reason why your proteasome inhibitors like bortezomib are highly effective in multiple myeloma. That is because once you inhibit the proteasomes, your I-kappa B levels will increase and NF-kappa B levels will decrease, which can reduce the survival and proliferation and production of immunoglobulin from the neoplastic plasma cells. Very important point. Clear? So this is how they do. The NF-kappa B is a very important molecule as far as this multiple myeloma is concerned. And again, one of the important agents that inhibit this NF-kappa B levels inside the, this transcription translation of this NF-kappa B molecules inside the cell are corticosteroids. Your glucocorticoids are corticosteroids, which means your steroids are also going to form a very integral part of the treatment as far as multiple myeloma is concerned. Okay, it's also very important for many other non-Hodgkin lymphoma also, but here also it's really important, especially dexamethasone is one of the very important therapies for multiple myeloma because it can reduce the NF-kappa B, not inhibit, reduce the production of NF-kappa B. Clear? The next question is how these plasma cells are going to cause lytic lesions. That's also very important because one of the important defining feature is they have to produce these lytic lesions. The plasma cells are the main reasons why they produce these lytic lesions in the bone marrow, in the bone. But how they do produce these lytic lesions? Let us see a different mechanism. These neoplastic plasma cells are going to secrete a factor called MIP, that is called macrophage inflammatory protein. This MIP has two functions. The first function is they will activate the stromal cells. In return to activation from MIP, the stromal cells are going to secrete something called rank ligand. This rank ligand is going to activate the osteoclast. This rank ligand is going to activate the osteoclast, which is going to cause increased bone lysis. Clear? Second one, they also inhibit the osteoblast directly. Once you inhibit the osteoblast, they are going to decrease the bone formation, which means the bone formation is terribly suppressed and the bone lysis is terribly increased. That is the reason multiple myeloma is also referred to as something called a pure lytic lesion without any osteosclerosis. There won't be osteosclerosis, it will be a pure lytic lesion. Because the osteoblasts are inhibited here, your bone scans will not be that much effective because bone scans depend on the osteoblastic activity. Here it is suppressed and almost zero, so you won't get any pickup in the bone scans typically. So that's why we don't use the bone scans, but we use FDG PET. PET scans we can use, but bone scans it's very unreliable for diagnosing bone lesions in a multiple myeloma because of reduced osteoblastic function. Clear? At the same time, one other principle how this plasma cells do survive is by their adherence to the stromal cells. They are going to adhere to the stromal cells. Adherence to the stromal cells is very important. How they are going to adhere to the stromal cells? Once they adhere to the stromal cells more and more, this stromal cells itself will start supporting the plasma cell growth, because the stromal cells are going to secrete lot of growth factors that is going to support the proliferation growth of plasma cells. And remember, these plasma cells generally don't come out of the bone marrow into the blood. If they come into the blood in sufficient numbers, we call that as plasma cell leukemia. That is different. But in general, plasma cells these malignant plasma cells remain strongly adhered to the bone marrow, and they don't come out of the bone. And from there itself, they cause all these effects: immunoglobulin production, osteoclastic activation, lytic lesions. All these things they cause within the bone marrow by adhering strongly to the stromal cells. And the stromal cells is the one that consistently starts producing the growth factor support to keep the myeloma cells intact and growing always. Clear? So now we have completed about the pathophysiology of multiple myeloma. Now, along with this thing, so we can see the clinical features. Clinical features, common features, we call it as CRAB features. Then you can call it as other features. This CRAB is very, very common. What are the reasons for, what are the components of CRAB features? C stands for calcium. So what is going to happen? The patient is going to develop hypercalcemia. Is hypercalcemia a universal feature? No, it will be seen only in 40% of the patients. For sure, only 40% of the patients. Then what are the reasons for hypercalcemia? I told you it is due to excessive osteoclastic activity. So remember, if there is excessive osteoclastic activity, there won't be only hypercalcemia, but there can also be associated hyperphosphatemia. Also remember, this hypercalcemia is going to completely suppress the PTH. And multiple myeloma patients also will have inhibition of osteoblastic activity. Since they have suppression of osteoblastic activity, their alkaline phosphatase levels also will be normal. So all these are very important. So high calcium, high phosphorus, low PTH and normal alkaline phosphatase. Undetectable PTH in fact many times. So this is very important point, but very commonly isolated hypercalcemia is also very, very common. But overall hypercalcemia is seen only in 40% of the patients. Number 2, you can have something called renal failure or renal injury. Renal failure, renal injury. Renal failure, renal injury can be of two types. One is having high serum creatinine, or second one is having high urinary protein, that is called proteinuria. Both are going to come under renal involvement and renal failure only. What are the reasons for renal failure? The topmost reason is, I would suggest you, it's a light chain deposition. Topmost reason must be, I will tell you, it's a light chain deposition. That could be the topmost reason. This light chain deposition, if it's severe, they can result in AL type of amyloidosis, or they can simply result in something called a type 2 renal tubular acidosis, or otherwise called a proximal renal tubular acidosis. All these things could be the reason for developing this particular type of renal failure. Next one, renal failure itself may be due to hypercalcemia or hyperuricemia, or because multiple myeloma patients, because of high immunoglobulin, they are also prone for type 1 cryoglobulinemia. Because of cryoglobulinemia formation also, you can get a renal failure. But as far as I know, the most important reason is the light chain deposition. That is what is going to result in renal failure most of the times. And the incidence of renal failure is not that much, it's only hardly 20%, 1 in 5 patients. Still, it's important to know. Third one you have is the anemia. Anemia is typically due to bone marrow involvement by plasma cells, because they are going to completely suppress the other cells' activity and they are going to take over as a neoplastic plasma cell. So that is the reason why you get anemia. Anemia is one feature which can be seen in approximately 50 to 60% of the patients. And typical anemia going to be normocytic anemia, because the bone marrow failure. So B stands for bone lesions. B stands for bone lesions. Bone lesions are supposed to be the most common, to be honest. These are the most common. Almost more than 80% of the patients tend to be having these bone lesions. What are the features of bone lesions? One is the lytic lesions, typically you see. Second one, they can even present with pathological fractures. Third one, they can even present with bone pain. Typically where there will be bone pain in the low back. Backache and low backache is one of the very important features. I didn't tell you in the clinical features, average age of diagnosis of multiple myeloma patients again 69 to 70 years, which means it's happening in elderly patient. That is the reason anytime when an elderly patient, especially more than 60 years, is coming to you with backache, new onset recently, and the patient is having AK typically in the serum creatinine in the range of 1.5 to 2.5 very commonly, with excess urinary proteinuria, please do screening for multiple myeloma. This is a very typical case of multiple myeloma in the exam. You do not have any other features to suggest it's a multiple myeloma. This clinical history itself will suggest you it's a multiple myeloma in exam. Okay, what are the other features? Other features, the patient may have recurrent infections, that is relative hypogammaglobulinemia, because of abnormal, aberrant, non-functional immunoglobulins, even though it's excess, functional immunoglobulin levels are low. Remember, that phenomenon is what we refer to as something called immunoparesis, because these neoplastic plasma cells, even though they produce excess immunoglobulin, these are dysfunctional. And they also suppress the normal immunoglobulin production, which means normal immunoglobulin production is suppressed, but these abnormal immunoglobulins which are non-functional are increased in number. So this is what we refer to as something called immunoparesis. And next thing, they can have neurological manifestations where they can produce demyelinating neuropathy, which can be due to monoclonal gammopathy itself, hypergammaglobulinemia itself. At the same time, they can have features of cord compression also, especially if it's happening in the vertebra, if the lytic lesions are there, sometimes pathological fractures can happen and it itself might result in cord compression. That's one of the neurological features. And Poem syndrome is a separate entity which we'll discuss later on, that also may have neurological features. Apart from that, they can develop hyperviscosity. Hyperviscosity is typically due to excessive immunoglobulins again, that increase the viscosity. So remember, gamma globulins are one of the agents that increase the viscosity nicely. After fibrinogen, gamma globulins are also very important that increase the viscosity of the blood. Fibrinogen is one of the relatively highest index for increasing viscosity, but not the most common reason for blood viscosity, but one of the things that has relatively maximum viscosity. I mean, if you take per unit one molecule of fibrinogen and any other molecule in the body, fibrinogen is the one that's going to increase the viscosity maximally. 1-to-1 ratio if you take. But since the fibrinogen levels are low compared to the globulin albumin levels and all, I mean, as overall, if you see, fibrinogen doesn't contribute that much viscosity, but if you take one-in-one molecule, fibrinogen has tremendously high viscosity in comparison with albumin or globulin. But anyway, globulin does have viscosity. If the, like if you have high globulin levels, your blood viscosity is going to increase. That's what he's asking. Increased hyperviscosity features will be there, like blurring of vision, shortness of breath, headache, flushing. All these things are hyperviscosity features. And remember, hyperviscosity happens once IgM levels are more than 4 grams per deciliter, or once IgG levels are more than 5 grams per deciliter, or once IgA levels are more than 7 grams per deciliter. This is the cutoff for developing hyperviscosity. Apart from that, they can develop coagulopathy. I told you the reason already, and they can develop amyloidosis also. All these things we have discussed already. There is no more discussion needed. All the other features of multiple myeloma. Clear? Investigations. What investigations you want to do for multiple myeloma? Remember, the idea of doing investigations in multiple myeloma, the first one is identify the paraprotein, the monoclonal immunoglobulin that they are producing. That's why we call identifying paraprotein. So what are the investigations you have for identifying this paraprotein? To identify this paraprotein, you have 4 investigations. One is called SPEP, that's called serum protein electrophoresis. Then you have something called SPI, that's called serum protein immunofixation. Then you have something called UPEP, that's called urine protein electrophoresis. Then you have UPI, that's called urine protein immunofixation. Remember, the sensitivity of this SPEP to identify this paraprotein is only 80%. When you are going to combine both this SPEP and SPI, the sensitivity becomes 93%. When you are going to use all these 4, SPEP, SPI, UPEP and UPI, your sensitivity typically becomes approximately 97%. So this is how sensitivity improves when you start combining all these investigations. Remember, the reason why SPEP sensitivity is not satisfactory, only 80%, is because you have to understand almost 20% of multiple myeloma does not secrete heavy chains at all. They secrete only light chains. Remember, light chains are freely filtered and can be excreted in the urine, and in the serum they do not cause the M spike also. It's very difficult to find out because the SPEP, what it relies on is by determining that M spike in the electrophoresis of the plasma serum. So M spike is due to heavy chain only. It is due to heavy chain only. Light chains generally do not produce the M spikes, and that is also one reason why since 20% secrete only light chains, you cannot find out. Clear? At the same time, patients who are secreting these light chains only, who can identify this? Suppose, what is the best thing to identify these patients who are having only identify these light chains? So they can identify by something called serum free light chain assay, that's called SFLC assay, or they can be identified by UPEP or UPI, that's called urine protein electrophoresis and urine protein immunofixation. It's really, really important. Clear? Why? Because I told you light chains will not be detected in the plasma compartment. Many of them it will be freely filtered, and in the urine it can be readily detected by urine protein electrophoresis itself and urine protein immunofixation. And SFLC, that's called serum free light chain assay, there's a separate assay which is directed and targeted towards light chain. So that is the reason why these 20% of the patients who secrete only light chains can be identified by either serum free light chain assay or by UPEP and UPI. At the same time, remember, one of the disadvantages of this SPEP, this serum protein electrophoresis, cannot tell you the type of paraprotein, which means it cannot tell you the paraprotein composition. Type of paraprotein cannot be identified by SPEP. At the same time, they cannot also confirm the monoclonality, which is a very important thing in multiple myeloma. Monoclonality is the defining nature of multiple myeloma. If it's a polyclonal, you cannot call it as multiple myeloma. Remember, it's a monoclonal single immunoglobulin of single specificity, antigen specificity, even though they are dysfunctional, and it could be either IgA, IgM or any isotype. So remember, the type, isotype or paraprotein composition cannot be detected by serum protein electrophoresis, and they cannot find out the monoclonality of that as well. For that only we have something called a SPI, that's called serum protein immunofixation. Remember, serum protein immunofixation, this these two disadvantages are rectified because the serum protein immunofixation can identify the composition of the paraprotein. Serum protein immunofixation can identify the paraprotein composition. At the same time, they can also tell you it is monoclonal, because if you have only one type of immunoglobulin that is rising, it's definitely monoclonal only. So what will be the paraprotein composition? IgG tends to be the most common, and IgA tends to be the second most common. And I told you light chains only can be secreted in approximately 20%, and immunoglobulin D can be secreted in 2%, and immunoglobulin M can be secreted in 0.5%, which means the least common type is the IgM secreting myeloma. It's very, 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 very rare. And there is also one important difference with Waldenstrom's macroglobulinemia, because in Waldenstrom's macroglobulinemia, the main paraprotein that is secreted is IgM, even though it's monoclonal. In multiple myeloma, IgM is extremely rare. The most common will be the IgG and the IgA. In exam, you will usually get this IgG as a paraprotein, very commonly. Clear? And one thing, why I put the line here? Do you understand this particular line? Why I put here? Can you understand? Because there is a variant called a non-secretory myeloma. Non-secretory myeloma, which is still contributing to non-secretory myeloma, which is still going to contribute to approximately 5% of the cases, which means these non-secretory myeloma patients cannot be detected by any of the tests what you do, because they don't secrete any light chains, because you cannot identify a paraprotein in the first place. If you don't have a paraprotein in the blood, how can you identify by any of these tests for that matters? So none of these tests can identify paraproteinemia, non-secretory myeloma, including a serum-free light chain assay. Then the UPEP and UPI, the urine protein electrophoresis is there, and you have this urine protein immunofixation. Remember, this is typically used for identifying your freely filtered light chains, because filtered light chains, this is the one that will be important, filtered light chains. Clear? So filtered light chains, how you can identify this? This filtered light chains in the urine, this is what we refer to something called BJP, the famous BJP, that is called Bence-Jones proteins. These are nothing but the freely filtered light chains. Remember, this filtered light chain are seen in approximately 2/3 of the patients, which means what I am trying to tell is, now you can ask me one question, sir, you told 20% secrete light chains only. But remember the fact I clearly told 20% secrete light chains only. I'm not telling this 80% will not secrete light chains. In that 80% also, a lot of patients may secrete light chains as a part of this immunoglobulin secretion. A lot of plasma cells may secrete these light chains as a part of immunoglobulin secretion. That's why overall, if you combine both these patients, approximately 2/3 of the patients will secrete this light chains in excess, and those light chains will be freely filtered in the urine, and those freely filtered light chains in the urine, that is secreted by light chain secretion only myeloma, as well as common myeloma, what you see, it secretes both light chains and heavy chains. So overall, in 2/3 of the patients you can see this, and those light chains that are freely secreted is what we refer to as BJP, which means BJP is positive in almost 2/3 of the patients with multiple myeloma. That's called Bence-Jones proteins. How will I identify BJP? This BJP can be identified only by urine protein electrophoresis or urine protein immunofixation. Remember, urine protein electrophoresis, you can identify the Bence-Jones proteins, but you cannot tell whether it's monoclonal or whether what is the composition of the immunoglobulin. But urine protein immunofixation can tell you what is the component of the immunoglobulin. At the same time, it can tell you the monoclonality also. So that is why it is special. But remember, both this UPEP and UPI are not currently used. Instead, this is largely surpassed by use of one more test that is already I discussed, that is called serum-free light chain. This is what we use currently to identify the light chains. Total light chains, it's emerging as one of the very good and highly sensitive tests in case of a multiple myeloma. This serum-free light chain assay. Clear? It's a very, very sensitive assay. Do you understand? Clear? And we are not doing UPEP and UPA anymore, even though many old And traditional nephrologists still prefer doing a urine BJP, but in our practice, we still prefer the serum-free light chain assay, which has largely surpassed for detecting these light chains. Clear? So these are the 4 investigations. I didn't tell you about this M protein and the M spike. Remember, this M protein and the M spike itself has many differential diagnoses. Remember, this M spike can be monoclonal, even though remember the clonality cannot be confirmed with the serum protein electrophoresis, but still I can tell this M spike has 2 components. One is it could be monoclonal M spike or it could be polyclonal M spike. Where you see a monoclonal M spike, typically you will see in a multiple myeloma, you will see in a monoclonal gammopathy of undetermined significance or uncertain significance. Then you will see in a CLL, I told you 5% of the cases, chronic lymphocytic leukemia. Then you see in certain lymphomas, you can see in sarcoidosis possible. You can see in other autoimmune disorders like rheumatoid arthritis and Sjogren syndrome. Rheumatoid arthritis and Sjogren. In this special importance, you have to give to Sjogren. But anyways, fine. So these are the monoclonal cause of M spike or M protein in the, like your serum protein electrophoresis and immunofixation. So polyclonal. Polyclonal typically you will see in HIV. You can see in a lot of other rheumatic autoimmune disorders and cirrhosis. HIV is very important. Many rheumatic disorders produce polyclonal rise in immunoglobulin levels. Even a lot of other infections also can produce. Anyway, these are the important DDs for M spike in the serum protein electrophoresis and serum protein immunofixation. So you have to be a little bit understanding about this. I told you, what do you mean by this serum free light chain assay? I told you something called serum free light chain assay. So remember this serum free light chain assay, I told you why this has surpassed this UPP and UPI, because it's now the most sensitive test for multiple myeloma. Remember, this will be still negative in non-secretory myeloma, but still this is supposed to be the most sensitive test currently, serum free light chain assay, because almost all plasma cells will secrete at least the free light chain. I told you 80% will secrete like normal immunoglobulins, and 20% are going to secrete only light chains. So that also can be picked up by this particular test, serum free light chain assay. This is most useful. If they ask you where it is most useful, it's most useful when patients, I told you 20% of patients secrete only light chain. So this is the area where it's going to be most useful. Clear? At the same time, it can be used for follow-up also, not only for diagnostic purposes. It can be, this is I told you for diagnostic purpose. So secreting light chain only, this is the most useful test. At the same time, for follow-up purpose also you can use this. How? You are going to see something called a kappa lambda ratio. This is the base of diagnosis, and the same kappa lambda ratio you can use for follow-up also, because this kappa and lambda are the 2 light chains that everyone knows. Kappa lambda, if you ask me, the normal ratio of kappa and lambda is 0.6, which means it's going to be 0.26 to 1.65. Remember, since multiple myeloma cells are monoclonal, they are going to either secrete only kappa or they are going to secrete only gamma. Lambda. So they are either going to secrete only kappa chains or they are going to secrete only lambda chains, which means the kappa lambda ratio, which is going to be skewed towards one side. For example, if kappa lambda ratio normally is 0.6, if only your kappa chains are increasing in multiple myeloma, this ratio will be increasing. Remember, if only lambda chains are increasing but kappa chains are normal, because it's a monoclonal, either kappa or lambda will increase but not both, because it's a monoclonal immunoglobulin that is secreted. If only lambda is getting secreted, now the ratio will be skewed towards this side where the ratio will be decreased. This skewing of ratio is very important. So that is what is confirms there is some problem in a serum free light chain assay. Either it will be skewed to the higher side or to the lower side depending on the kappa lambda ratio. That's what is very important. This is what we refer to as something called a free light chain assay. And how can you use it for follow-up itself? Because I told you the idea of treatment is to reduce the production of immunoglobulin so that the ratio will once again become normal. So that is the reason why you do this SFLC for follow-up purpose also. That is the reason I'm telling This is a very commonly employed test right now, because in my practice itself I am doing only this kappa lambda ratio and serum free light chain assay, and a very important test. Serum free light chain assay, it could be a very important question for your exams. Clear? So then for identifying the lytic lesions, I mean, in my practice we use a plain X-ray most of the times, or you can use a CT also, or you can use an MRI also, or you can use typically a PET CT also. PET scan also can be used. But remember, bone scans will not be useful because of the poor uptake by the osteoblast, because the osteoblastic activity is suppressed. You can try anything, but like depends. I go for simple X-ray in the beginning. If I have strong suspicion, then I take either an MRI or a PET, depending on the affordability. But anyway, all these three things are equally valid for detecting the lytic lesions. For assessing the tumor burden, you have two things. One is called LDH and second one is called beta-2 microglobulin, of which the most important is the beta-2 microglobulin, because the original Dury-Salmon staging has gone now. Currently we are using only this beta-2 microglobulin as a very, very, very powerful prognostic factor and a marker of disease activity in case of a multiple myeloma. So that's a very important point to note. And next thing, you have something called cytogenetics. Cytogenetics are there. So again, cytogenetics in multiple myeloma are really important, like what I told you for CLL. So there are two types of cytogenetics. One is called a standard risk, which means you can take it as a good prognostic factors. And next one, you have high risk cytogenetics, where you can call this as poor prognostic factors. Standard risk means the patient will have hyperdiploidy, is a standard risk. Translocation 11-14 is also a standard risk. This means it's okay, good, maybe, not bad. Remember, this hyperdiploidy is a very, 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 very important one. Clear? For exams. For exams, not for real time, but exams is a very important thing, many times asked. Similarly, hypodiploidy is a high risk factor. Again, it's a very, very important point. Hypodiploidy is a high risk factor, whereas your hyperdiploidy is a standard risk. Again, both are very important for exams. And here, deletion 17p. I think you would remember, aren't you? The last lecture we saw this. Deletion 17p is a favorable prognostic factor in case of a CLL, whereas it's a poor prognostic factor for a like your multiple myeloma. Clear? Deletion 17p is there. Sorry, deletion 17p is also poor for CLL as well. Sorry for that. We'll come back to that. Deletion 13q is what I mean. This deletion 13q is a favorable prognostic factor in case of a CLL, whereas it's a poor prognostic factor in case of a multiple myeloma, because deletion 13q is one of the commonest, one of the most common cytogenetic change that you see in a CLL patient. So it's poor. That's there it is good actually, if you go back and see. Deletion 13q. Then you have something called deletion 11q, not that important for exams. Then you have something called T414, that's translocation 414. Then you have translocation 1416. Then you have translocation 1420. And you have something called gain of 1q chromosome, 1q gain. All these things are important. Apart from that, for exam's sake, if you ask me, this forms the crux. 17q, 17p, 13q. Then you have this hyperdiploidy and hypodiploidy. Remember, hyper, good, reasonable, standard risk. Hypo, definitely poor, hypodiploidy. 13q and 17p, deletion, definitely poor prognosis. But surprisingly, if you ask me, what are the things that are involved in international staging system? Recently is, this one is involved, given in international staging system for multiple myeloma. And this 414 is given in international staging system and 1416 is given in international staging system. Only these three are given as important cytogenetic changes for multiple myeloma in international staging system, because currently ISS only is being preferred, and even the beta-2 microglobulin related classification of prognosis is getting slowly out of favor, and they are trying to involve more of cytogenetics into the picture. Clear? So that is the reason why currently your something called international staging system is coming out. So that is what is becoming more favorable now. In that they have introduced a lot of cytogenetic changes also into the staging systems. So the future will be more of cytogenetics only. So that is the reason I told you these three findings, these three are the ones, this deletion 17p, translocation of this 414 and 1416 is the one that are included in the cytogenetics of, include in the staging system of international group of multiple myeloma. That's called ISS, International Staging System. But remember, for exam's sake, whatever I put in pink, whatever I marked in pink is very important, because this hyperdiploidy and hypodiploidy, they have, I don't know how many times they have asked, so many times they have asked. That's why it's important. Clear? So one more important thing to know is a normal karyotype is always better than an abnormal karyotype. No matter what, I told you this is standard risk. I told you hyperdiploidy is a good thing, but even better thing is to have a normal karyotype. Normal karyotype is always better rather than having some problem like hyperdiploidy, even though we call it standard risk, but still rather than having this, if you have a normal karyotype, it's even more better. Clear? And immunophenotyping, that's when you do IHC or flow cytometry. IHC or flow cytometry in immunophenotyping, what will be the markers? These cells are CD20 negative. Very, very, very important. This is a very important point, because it's very well known fact that this post-germinal centers, especially these plasma cells, will lose this CD20. I told you very clearly, they don't retain the CD20 molecule. Very important point, therapeutic aspect, because rituximab will not be helpful in multiple myeloma. CD20 negative, because these are plasma cells. They shed off the CD20 once they become the plasma cells. CD20 negative, and they are CD38 positive and CD138 positive. Majority of them, yeah, true, because these are plasma cell markers. 38 positive and 138 positive. In this, if you ask me, is 138 assumes a lot of importance, really. 138 positive. And CD38 is variable, it's not negative or positive, it is highly variable, but in general, for exam's sake, you can remember CD38 is positive. 138 is definitely positive. 138 is very important thing. Okay. What are the diagnostic criteria for doing a multiple myeloma? Before that, let us see some images for that matters. If you see these images, you can see what I'm trying to tell. You can see a lot of lytic lesions. You can see lytic lesions. A lot of lytic lesions are there, and in the skull also you can see a lot of lytic lesions. You can see these are all lytic lesions in the skull. So extensive lytic lesion. This is suggestive of some lytic lesion. Typical, you will see this picture in 1 or 2 cases. This skull picture, if you see, think about either, this skull picture, if you see, think about either it's a multiple myeloma, or even it can, similar skull picture of a child with lytic lesions may be given exam for Langerhans cell histiocytosis also, which we discussed already. At the same time, this one is there is a normal electrophoresis, this serum protein electrophoresis, normal one. This is a multiple myeloma picture. You can see this is what we call M, because it looks like M, isn't it? This is what we refer to as this M spike, and this is the one. You can see typically the M spike in the gamma globulin zone. Very important. They will ask you where will you see the M spike. You will see the M spike in the gamma globulin zone in the serum protein electrophoresis again. Okay. With this, we can go into the criteria for diagnosing multiple myeloma. So what are the criteria? Along with that, we can see the diagnostic features also. Criteria for diagnosing multiple myeloma. Number 1, your bone marrow biopsy or bone marrow aspiration. You are seeing plasma cells. Typically, that should have the clonality, and if this clonal plasma cells are more than 10%, clear, in the bone marrow. Remember very clearly, it is 10%. In the bone marrow, if the clonal plasma cell values are more than 10%, or if it's a biopsy proven multiple myeloma. If it's a biopsy proven plasmacytoma. If it's a biopsy proven plasmacytoma, plus you should have, which means you are diagnosing a plasmacytoma somewhere in the body, plus you should have at least one, minimum of 1, more than or equal to 1 MD, that's called myeloma defining event. So this is the criteria for diagnosing multiple myeloma. Either a bone marrow biopsy showing, or a bone marrow aspiration showing clonal neoplastic plasma cells, which is contributing at least to 10% minimum, or a biopsy proven plasmacytoma anywhere from the body plus 1 myeloma defining event. So now what is the myeloma defining event? So myeloma defining event are 2 are there. One is called something called ROTI. The first one is called ROTI or ROTI. That's called myeloma related organ or tissue impairment. That's called myeloma related organ or tissue involvement. This is called ROTI. So this could be like typically your CRAB criteria. So any of the CRAB, if it's there, it mixes into the ROTI. For example, if you have hypercalcemia, if you have renal failure, or if you have anemia, or if you have bone lesions, lytic bone lesions, that is equivalent to ROTI. That is equivalent to ROTI. Usually any one of that is there, you can call it a ROTI. But they are given a value, that's all. If calcium is more than 11, creatinine is more than 2, HB less than 10, and at least one lytic lesion. At least one lytic lesion in the bone. So they are given some additional point, that's all, nothing else. Second one, you have any other biomarker. Any other biomarkers of multiple myeloma, like bone marrow, plasma cells, more than 60%, whether it shows clonality or not. Second, serum free light chain ratio more than or equal to 100:1, FLC more than 100:1, or it's skewed towards any one side, that's what I mean. So it's 100:1, or if you have any more than one focal lesions in MRI. If it's more than one focal lesions in MRI. Why 100:1 I told you is because in multiple myeloma there will be so much elevation free light chains, so that we take which is higher, that will put on the numerator, and which is lower will put on the denominator. Even if you put like that, the ratio will not become 100 for anything, because if one particular light chain kappa or lambda is 100 times more than the other light chain, definitely it proves that it is some light chain secreting neoplasm is going on. So it itself tells you it's a monoclonality. So that is why it is very important to understand. So these are the three myeloma defining, other things that are coming under myeloma defining event. So remember, the first one, you should have this ROTI, any one, or second one, you should have this any one of this. So if you have, you can put this under one of the myeloma defining events, and you can tell along with the biopsy grown plasmacytoma, if one myeloma defining event is there, you can diagnose a multiple myeloma. Then now the criteria is over, but there are some other findings you can see in multiple myeloma that are asked for exams. Very commonly, very high ESR. Multiple myeloma is one condition where you have an ESR of even 200, 100, very, very high ESR. And the smear will show increased Role formation. That's also very important. This Role formation is very classical in multiple myeloma. Let us see that now. You can see this is a typical Role formation. A lot of Role formation are there here. So this is one example of Role formation. This is typical in a multiple myeloma, not specific but very typical. And you can see these are neoplastic plasma cells that are having eccentric nucleus and cartwheel-like nucleus. You have studied in pathology, I'm not going to discuss. So these are eccentric cartwheel-like nucleus, and you can see a lot of cytoplasmic vesicles that are actually to secrete the immunoglobulin, because they secrete immunoglobulin in very high numbers, that's why. Clear? So these are all the neoplastic plasma cells in the bone marrow. And you can see one thing, this image is to show two things. One is called Russell body and second one is called Duce body. Here I am going to show the Russell bodies. Russell bodies. Russell bodies are nothing but these are intracytoplasmic vesicular inclusion bodies. You can see these are intracytoplasmic vesicular inclusion bodies. These are what we refer to as something called Russell bodies, and the plasma cells that are harboring these Russell bodies, we are going to call them as Mott cells. Mott cells are nothing but the plasma cells that are harboring these Russell bodies. And then you have Duce bodies. Duce bodies. What do you mean by Duce bodies? Duce bodies are intranuclear vesicular inclusions. See, the cytoplasmic is different. This is the cytoplasm, but this is the nucleus, isn't it? Intranuclear vesicular inclusions, if you have, that is what we refer to as something called Duce bodies. Both, Russell bodies and Duce bodies are due to enhanced immunoglobulin production. That is the reason. Clear? So now let us see the differentials one by one. What are the DDs and how to differentiate each and every disease and the variants of multiple myeloma. That's a very important table which I'm going to tell. Please be very careful here. One you called as MGUS, that's called monoclonal gammopathy of undetermined or uncertain significance. Second one, you have a smoldering myeloma. Third one, you have a multiple myeloma, as I told you. Then you have something called a non-secretory myeloma. Then fifth one, you have a plasmacytoma, and finally I can tell Waldenstrom's macroglobulinemia. It's not a variant, but still you can put it under as a differential. It's very important table. This is how you diagnose an exam. So number one, whether you get the Crab features or not in MGUS, absolutely no. You don't get the Crab features. Smoldering myeloma, no. Multiple myeloma, yes, because multiple myeloma is known for its symptoms. Symptomatic myeloma is what we refer to as multiple myeloma. And non-secretory myeloma, yes. Remember, non-secretory myeloma has all the features of multiple myeloma, including the Crab features. But why they are non-secretory is because this neoplastic plasma cell lose the ability to secrete those immunoglobulins. If you take the biopsy and see a non-secretory myeloma plasma cell, it will also, its cytoplasm also will be fully filled with vesicles and full of immunoglobulins will be there, but it's just that they cannot secrete them. That's such a secretory defect of this. It's like multiple myeloma only. It's just a secretory defect that doesn't make the plasma cell secrete the immunoglobulin. So that is what we call a non-secretory myeloma. But if you put an immunoglobulin stain and see, the cytoplasm of this non-secretory myeloma plasma cells will stain intensively with immunoglobulin because they cannot release them and a lot of immunoglobulins will be accumulated inside. Very important point to know. Which means they are also symptomatic only. The only difference is they don't secrete, that's all. And plasmacytoma, no, they won't have any symptom. And Waldenstrom macroglobulinemia, typically they don't have any symptom again. And which means the Crab features. Symptom in the sense I'm talking about the Crab features, not the hyperviscosity. Crab features is what I'm talking about. Paraprotein levels. In MGUS, it is less than 3 grams per deciliter. In smoldering myeloma, it is more than 3 grams per deciliter. Definitely in multiple myeloma, it also should be more than 3 grams per deciliter. Non-secretory myeloma, it is less than 3 grams per deciliter because they don't secrete the paraproteins adequately. But in smoldering myeloma is nothing but a asymptomatic myeloma, which means it's going to show all the features of myeloma except for the Crab features, which means they also have the paraproteinemia. Plasmacytoma, it's variable. I mean, certain plasmacytomas, there can be M spike and more than 3. Certain plasmacytomas they don't have the M spike and they secrete less than 3. It depends. Again, Waldenstrom's, it's more than 3 grams per deciliter. It's a monoclonal gammopathy again. And serum free light chain ratio. Remember, in MGUS, it can be normal or increased. In plasmacytoma, again, it's variable. It can be normal or increased depending on whether they secrete or not. And in Waldenstrom's, I mean, all the other conditions, the serum free light chains will be increased, except it will be completely normal and definitely must be normal because they can't secrete anything, non-secretory myeloma. Then you have other immunoglobulin production, that is normal immunoglobulin production. Other immunoglobulin production, it is normal in case of an MGUS and normal in case of a non-secretory because they can't suppress the other immunoglobulin production, and variable, again variable in case of plasmacytoma because depends on how much immunoglobulin they secrete. And Waldenstrom's definitely reduced. Here it's reduced, and multiple myeloma again it's reduced. Clear? What I'm trying to tell is this smoldering myeloma and multiple myeloma, the only difference is the symptoms, the Crab features. That's it. Apart from that, the smoldering myeloma is going to behave like a multiple myeloma only, except for the Crab features. Fine. Bone marrow. Then let us see the bone marrow. In bone marrow, the plasma cells are going to be less than 10%. I'm going to tell plasma cells or your LPL. I'll tell you what is LPL. You have lymphoplasmacytic lymphocytes. This is, lymphoplasmacytic lymphocytes will be seen in Waldenstrom's macroglobulinemia. This actual plasma cells will be seen in other conditions. Whatever other conditions which I have told you here, right from multiple myeloma, smoldering myeloma to plasmacytoma, all these things we are considering the bone marrow plasma cells only. But in Waldenstrom's macroglobulinemia alone, we are going to consider the lymphoplasmacytic lymphocytes, not the actual plasma cells. Here, obviously it will be more than 10% because I told you it's a myeloma but asymptomatic without Crab features. Again here it will be more than 10% plasma cells, and again in non-secretory again it will be more than 10%. Again I told you The only difference between multiple myeloma and smoldering is the CRAB features, whether present or not. The only difference between a multiple myeloma and a non-secretory myeloma is the immunoglobulin levels. I mean immunoglobulin and the paraprotein, which they don't secrete. Clear? Apart from that, everything will be the same. Bone marrow again will show more than 10% plasma cells, whereas here typically in a plasmacytoma it must be less than 10%, and in Waldenstrom you will see more than 10% of LPLs, not plasma cells, lymphoplasmacytic lymphocytes. That's the problem in Waldenstrom's macrogloma. It's LPL, not your plasma cells here. So this is what is happening. So remember, if you take a MGUS, so let us see what are the idea between these MGUS. Now the entire ideology of MGUS is changed. If you look at this image, you will understand why the idea has changed. If you see what is happening, so now initially a normal patient, you can see this particular type of plasma cells. You can see plasma cells over here. Clear? Now they go to a MGUS initially, which means now they are thinking that this monoclonal gammopathy of uncertain or undetermined significance is almost the universal precursor thing to multiple myeloma, which means if I'm going to develop multiple myeloma, or if I already developed multiple myeloma, 10 years back or 5 years back, I would have had an MGUS, which is because MGUS patients are asymptomatic, their paraprotein levels also very less, they don't go for any symptoms. Unless until you detect them, you will not find out them at all. You do by any other testing and you find out. It's not possible. That's why now the current concept is any time you get like multiple myeloma, it's always preceded by an MGUS, monoclonal gammopathy of uncertain significance. That is what the current idea is. Then it progresses to something called a smoldering myeloma, which means initially in here there are no symptoms, and also the paraprotein levels will be less than 3 grams per deciliter, which means they will secrete the paraproteins, but the paraprotein levels will be less than 3 grams per deciliter. But remember, whatever paraprotein they secrete will be monoclonal. All this will be there, but it's not that extent of paraprotein that you have to produce the symptoms. At the same time, they won't have CRAB features. Smoldering myeloma is where the paraprotein levels start becoming more than 3 grams per deciliter, which means the paraprotein level starts increasing, but the patient will not have again any symptoms, no CRAB features. So first less than 3, no CRAB, then they will become what? More than 3, still no CRAB, then finally they will go to the symptomatic phase where the paraprotein will become more than 3 grams per deciliter and you start developing this CRAB features also. So how beautifully they evolve. So this is what we think, and it's proved to be the evolution pattern of a multiple myeloma. Suppose if multiple myeloma plasma cells are reaching out I told you they should reside in the bone marrow predominantly. If they come out into the bloodstream predominantly, which means by definition if the plasma cell numbers become more than 2000 per microliter or 2000 if it exceeds in the blood, that is what we define as something called a plasma cell leukemia. Now you can know it's nothing but a multiple myeloma or any other thing where the plasma cells leak out of the bone marrow and come into the blood, and if you see that cutoff is more than 2000 per microliter, then you can call it as something called a plasma cell leukemia. Similarly, the same way your Waldenstrom's macroglobulinemia also is going to evolve. Similarly, like an asymptomatic MGUS related IgM MGUS will be there. Later on, they'll become smoldering Waldenstrom's, which means asymptomatic. Then finally, they'll become symptomatic Waldenstrom's macroglobulinemia. This is how they, think. This is how it works. And if you ask me about MGUS, I didn't tell you there. I should have told you there. MGUS. What is the risk of developing multiple myeloma? It is 1% per year. 1% per year risk of developing multiple myeloma, and there is overall 25% lifetime risk, overall risk, 28% overall risk for developing multiple myeloma. Clear? So if it's remember, and again at the same time, if MGUS is of IgA, IgG or IgE or any other IgD type, there is a lot of chance it might move to multiple myeloma. If MGUS is of IgM type, then there is a lot of chance that they may move into Waldenstrom's macroglobulinemia. Both are important. Okay. Depending on what type of MGUS you see also, your type of disease evolution over time will also be changing. And again, similarly, I told you in a smoldering myeloma, I didn't tell you that. What do you mean by smoldering myeloma? Smoldering myeloma is where the patient is called an asymptomatic myeloma. Typically, you should not call asymptomatic because they don't have only crab features, that's all. But paraprotein levels will be more than 3 grams per deciliter. More than 3 grams per deciliter, which means you will have an M spike. Definite M spike will be there in serum protein electrophoresis, or serum free light chains and all will be increased, and typically you can find out the paraprotein somehow. But the patients will not have crab features. Because why diagnosis of smoldering myeloma is important? Because suppose if you have an occult lytic lesion, suppose if you have an occult bone lesion, occult bone lesions, typically if you have an occult lytic lesion somewhere in the bone, now the diagnosis with paraprotein more than 3 grams per deciliter with lytic lesions, now the diagnosis will become multiple myeloma and not smoldering myeloma. Clear not? That is the reason to detect this occult bone lesions, you need a PET CT or a whole body MRI. You need a whole body PET CT or a whole body MRI. You have to rule out this occult lytic lesions, then only you can make the diagnosis of smoldering myeloma. Very important point. If you miss out this occult lytic lesions, you will be considering this as a smoldering myeloma only, which means smoldering myeloma many times you don't treat only. That's the problem. It's only observation. You will observe over time. But if you prove it's a multiple myeloma, you have to start the treatment. That is the big difference. You have to do a PET CT or MRI in a suspected smoldering myeloma, where you have to rule out all the occult lytic lesions. Along with that, if you sure you don't have any crab features, then only you can diagnose smoldering myeloma and you can just observe. If you have any occult lytic lesion, it goes towards multiple myeloma as a possibility, and definitely you have to start the treatment. Clear? And yeah, a lot of differences are there. So these are the important things about this multiple myeloma and all these things. So let us go on to the staging now, staging systems. Staging. Staging, you have two criteria. One is called ISS criteria and second one is called Dury-Salmon. Remember, as I already told you, ISS is based on beta-2 microglobulin levels, beta-2 microglobulin and albumin levels. This is what it is based on. Whereas Dury-Salmon is based on hemoglobin, calcium, lytic lesions, as well as the paraprotein levels. Clear? So these are things that, not all the crab features. Creatinine will not be there in Dury-Salmon. Anyway, so these are the things that will be included in Dury-Salmon. These are things that will be in ISS. ISS is the one that is preferred now. That's called International Staging System. IS is the one that's preferred, and in that why IS is given beta-2 microglobulin. As of exams, you have to always understand beta-2 microglobulin is considered to be the most important prognostic factor for multiple myeloma patients. Even though cytogenetics play a vital role in the recent times, beta-2 microglobulin is traditionally considered to be the most powerful prognostic factor in a multiple myeloma. So stage 1 in Dury-Salmon, in ISS, if the beta-2 microglobulin levels are more than 3.5 milligrams per liter and serum albumin levels more than 3.5 grams per deciliter, it means it's a healthy patient. Not really. Sorry, beta-2 microglobulin should be less than 3.5. Sorry for that. Beta-2 microglobulin should be less than 3.5, which means low beta-2 microglobulin plus nice albumin levels indicates a relatively healthy patient, and it's a stage 1. Stage 3, if beta-2 microglobulin, irrespective of albumin levels, if it's more than 3.5, I told you beta microglobulin is a very powerful prognostic factor. If it's more than 3.5, irrespective of what albumin, normal or low albumin, doesn't matter. It is stage 3 only. So stage 2 is something in between, which doesn't follow either stage 1 or either stage 3. For example, examples of stage 2 you can tell where beta-2 microglobulin is less than 3.5, but albumin is also less than 3.5. Typically this will come under what? A stage 2. A very classic example of a stage 2 in ISS. Dury-Salmon, I told you, it includes a lot of criteria. For example, but anyway, Dury-Salmon is not important for exams. They will ask you only beta-2 microglobulin based cutoffs. So hemoglobin more than 10, calcium less than 12, just less than or equal to 1 lytic lesions, not much lytic lesions, or paraprotein levels IgG less than 5, IgA less than 3, or urine light chains. I mean, we don't use it all, isn't it? We use serum free light chains. So that's why it's a very old one, this Durisalmin. Urine light chains, if it is less than 4 gram in 24 hours per day. So these are the Durisalmin stage 1. Stage 2, if the hemoglobin is less than 8.5, calcium, like more than 12, then more than 5 lytic lesions, more than or equal to 5 lytic lesions. Or if IgA more than 7 grams per deciliter, or IgG more than 7, IgA more than 5, or if urine light chains are more than 12 grams per day, 12 grams in 24 hours. This is what we call as Duri. Remember, in stage 1 you need all the features. Everything should be matched. In stage 3, if any one is present, then also you can call it as stage 3. That is the difference between Durisalmin stage 1 and stage 3. And again, as usual, Durisalmin stage 2 is something in between. Clear? So remember, Durisalmin, even though I explained it's not important for exams, ISS is the one that is important. Currently, remember, they have given revised ISS staging. In revised ISS staging, they are additionally using LDH and cytogenetics. I told you the 3 cytogenetics that are very important, the most important being the 17p deletion. I told you, then they have included the translocation 1416 and 414 as well. So all these cytogenetics are really important to know for exams at least. But anyway, in revised ISS only they are using this cytogenetic changes for staging of multiple myeloma. Remember, only for revised ISS staging. They don't use this cytogenetics for the original old ISS one. So this is the ISS one. Remember, if they ask you the most powerful prognostic factor for multiple myeloma, answer must be beta 2 microglobulin and nothing else. Okay, clear. So average survival also varies. I didn't tell you that. Okay, I'll finish off that as well. Survival in a stage 1 patient is approximately 60 months, that is 5 years. Survival in a stage 2 is approximately 40 months, that is around maybe 2.5 years, maybe. Yeah, no, 3 years. 3.5 years. And in stage 3, it is only like 30 months. It's 2.5 years. Clear? So approximately 5 years, then 3.5 to 4 years, then 2.5 years. So these are the survival between stage 1, stage 2 and stage 3. I remember as 60, 40, 30. That's it. So this is the survival of stage 1, stage 2 and stage 3. Then you have treatment aspect of multiple myeloma. Remember, there are so much of treatment out there, and you have to check a lot of things before starting the treatment for a multiple myeloma. So what are the treatment options you can use? Number 1 are the classic proteasome inhibitors. What are the proteasome inhibitors you have? You have something called bortezomib. Then you have carfilzomib. I told you the mechanism of how proteasome inhibitors work already. Already we have discussed, so no need to discuss anymore. Carfilzomib. Then you have something called ixazomib. That's called like. So that's how it works. And in that, the most commonly used one is the bortezomib. So you have to note the side effects of bortezomib. So one of the important side effects of bortezomib is peripheral neuropathy. Clear? And this carfilzomib and ixazomib are considered as second generation proteasome inhibitors. They are going to have reduced incidence of peripheral neuropathy. At the same time, remember, this carfilzomib and ixazomib are oral drugs, whereas bortezomib has to be given IV. Clear? Bortezomib has to be given IV route, but carfilzomib and ixazomib can be given as oral route. Number 2, you have a lot of immunomodulators also. For example, like you can use lenalidomide. This is what is famous right now, like bortezomib there, lenalidomide. Then you can use something called thalidomide. Then they have something called pomalidomide. Clear? Everything. See, remember the one drug that has very high risk of peripheral neuropathy again is your thalidomide. Remember your lenalidomide and pomalidomide as a reduced incidence of peripheral neuropathy. All these things, but they can cause cytopenias. Very important. Bone marrow failure, and all these things can cause thromboembolic manifestation. Both are very important again. Especially with pomalidomide, you have to understand. Thromboembolic manifestations is very common. So this is again a very important thing to understand. Clear? So these are the immunomodulators. Number 3, they have other drugs you can tell which are active. Other drugs that you have to know is the steroids. Typically what we prefer in multiple myeloma is dexamethasone. Then you have alkylating agents like melphalan. You have certain drugs called panabinostat. Panabinostat is a HDAC inhibitor. That's called histone deacetylase inhibitor. A lot of drugs are there in HDAC inhibitors. One of the important drug is panabinostat. But if you want to know how HDAC inhibitors work, you have to know what you mean by epigenetics. Epigenetics is very important to understand. So remember, you have your nose, you have your ears, you have fingers, you have your eyes, you have tongue, you have lips. But my question is, why your lips look like lips? Why your skin look like skin? Why your lungs look like lungs? Why your eyes look like eyes? Why your fingers look like finger? Why your tongue looks like tongue? Simple. It's because of your epigenetic changes. Remember, if you take a DNA sequence, every single cell's DNA is one and only the same. Absolutely no difference. It's going to have the same DNA sequence. But how these changes are possible? Because there could be a lot of genes. Clear not? This gene can code for how your eye should look. This gene can code for how your tongue should look, and this gene can code for how your skin should look. For example, if a cell is going to differentiate into something that produces skin, you should suppress these genes that make up your tongue, or you should make up the eye, and only the genes that produce the skin tissue or that resemble the skin must be activated. It's a very simple thing. So how we are going to suppress this? Tongue and eye. These are called as epigenetics. That is why these are called as heritable changes. Heritable DNA changes that is not going to cause any disease. So that is the definition of epigenetics. Clear? So these are, this is what we call as epigenetics. So how they do this is principally by two mechanisms. I can discuss in detail later on. Principally by two mechanisms. One is called DNA methylation and histone deacetylation. Histone deacetylation. Deacetylation. Remember, whenever you have a DNA, this DNA is wound around this molecules called histones. So this is the DNA, and the black one is called the histone. Remember, by doing methylation of the DNA, you can silence a certain gene. For example, if this gene I don't want, I can methylate this particular area so that this particular gene or DNA area will not be expressed. To silence, to hide these genes. That's what's happening. So to do histone deacetylation, again, you have to silence. So which means the background histones are there, these histones, the black ones which I have drawn. So if you are supposedly doing this histone deacetylation in this particular area, again you are going to silence this particular gene, in that particular DNA area. So you are going to silence the gene again. So which means in the skin area, I don't want this tongue and the eye genes to be expressed. So this is how I silence, either by doing a DNA methylation or a histone deacetylation. Remember, there are a lot of DNA methylation. The DNA methylation typically done by an enzyme called DNMT. There are various varieties of DNMT are there. Maybe if there is time, and in some other lecture I will discuss you about DNMT. This is called DNA methylases. And similarly, you have a lot of HDAC enzymes also, that is called histone deacetylases. Remember, some cancers, I'm not telling all the cancers, some cancers may result from mutations of this DNA methylases which can be acting too much rather than what is required. So why DNA methylation? For example, this silencing, when cancers happen, is when the silenced gene is suppose let us assume is a DNA repair gene, which means this DNA repair gene is a good gene. Suppose if these genes are suppressed, if these genes are silenced in a cell, you are going to result in increased incidence of these cancers. Typically, a lot of hematological cancers. And one important hematological cancer that is due to mutation. Lot of hematological cancers come from this mutated hyperactive DNA methylases that silence the DNA repair genes. But the most important hematological proliferative disorder is MDS, myelodysplastic syndrome. Lot of MDS types are due to hyperactivation of this DNA methylases. One of the important inhibitors of this DNA methylases, we have a drug called azacitidine. This is a DNA methylase inhibitor. Similarly, you have an inhibitor of this HDAC, because one of the important neoplasm where HDAC will be hyperactive is multiple myeloma. One second. That is the reason this HDAC inhibitor, one of the important is panabinostat. Clear on? Many other HDAC inhibitors are there, varinostat, belinostat, and the third one we have something called a panabinostat. Clear? All these things are HDAC inhibitors only. Clear? So that is the reason why we use HDAC inhibitors here. Other drugs where you can use this HDAC inhibitors. Then you can have this immunotherapy in the form of something called elotuzumab. Elotuzumab is something referred to as something called anti-SLAM7 monoclonal antibody, which is again the SLAM7 is the one which is thought to be one of the reasons for developing a multiple myeloma. That's why anti-SLAM7 is helpful here. Then you have other immunotherapy. You have something called daratumumab. This is nothing but anti-CD38, which is commonly expressed by multiple myeloma cells. Then you have something called CARDS. We discussed already, isn't it? In the particularly where we discussed about these CARDS in the previous lectures. Somewhere I discussed about the CARDS as well. But here also the CARDS are really important. We are trying to produce this anti-BCMA T cell receptors. Remember, this BCMA is one receptor that is important for proliferation and survival of B cells and plasma cells. So we can genetically engineer these T cells to have this T cell receptors that can target this BCMA molecule, so that we are using our own genetically engineered T cells to damage the molecules what we want. That's the idea of CARDS. These are genetically engineered T cells. We discussed already. So CARDS. Elotuzumab, what it does is it activates the NK cells also. This anti-SLAM7 is going to activate the NK cells, which can kill the multiple myeloma cells, plasma cells. So these are some of the other therapies that you can use. Apart from that, a lot of adjunctive therapies are there. These are not other therapies, just adjunctive, not the main therapy. You can use the bisphosphonate therapy to reduce the risk of fractures. Then you have radiotherapy for symptomatic bone lesions. Even for pathological fractures, you can use this radiotherapy, symptomatic bone lesions. Then IVIG infusions you can use. I told you, because recurrent infections like CLL, you can use this IVIG. Then you can use plasma exchange or plasmapheresis. Typically, this is used for AK and hyperviscosity syndromes. Most importantly, for hyperviscosity syndrome, this is very important. Plasma exchange. Apart from that, all these are also some adjunctive treatments which is used as per the patient's symptoms are warranting the treatment. So then, if you want to know the management, how can you put the management in the nutshell? So treatment wise, I can do it two things. One, older patient, by definition more than 77 years, plus obviously they will be, or I can tell, or older itself is transplant ineligible only, or if the patient is transplant ineligible. A lot of reasons why the patient is transplant ineligible. So if the patient is transplant ineligible, we are going to do only chemotherapy. Typically we do an induction chemotherapy plus a maintenance regimen. Remember the classic induction chemotherapy, we prefer something called a triple treatment. Triple treatment, clearly we prefer something called a proteasome inhibitor in the first place. Characteristically in India we use bortezomib. Then we have dexamethasone, a steroid. Then you have a lenalidomide. There is something called a double therapy where you use only proteasome inhibitor and lenalidomide. But that is not, that is okay, but this triple treatment has more benefit and more effect compared to the double treatment with protease inhibitor only, protease inhibitor and lenalidomide only. So use triple treatment if at all you want to use. Remember, then this is the important induction therapy. This is multiple times asked questions in exam. Then you have your younger patients. If the patient is younger, that is typically by definition in this is less than 77 years, plus at the same time if they are transplant eligible. Initially in these patients what we do is we do an induction chemotherapy, same treatment what you are going to use, then followed by a high dose chemotherapy, high dose melphalan. Why is this? Is to damage all the cells whatever you have in the body. High dose melphalan, then followed by autologous hematopoietic stem cell transplant. Remember, multiple myeloma is not a stem cell defect, so you can use this autologous hematopoietic stem cell transplant because multiple myeloma is not a stem cell defect. Because if there is a stem cell defect like PNH and all, you can use only allogenic stem cell transplant. You cannot use autologous. Since this is not a stem cell defect, you can take the patient's own stem cells and you can re-inject at a later time. So autologous autologous hematopoietic stem cell transplant, these are the different things you are going to do in a multiple myeloma patient. Clear? So then what are the therapy for other related disorders? You have something called MGUS which you want to treat again. MGUS, it's only observation. There is no need to do anything. Plus at the same time you have to do serum protein electrophoresis every 6 months. Then once if stable at the 6 months mark, you can do every year, annually. Annually you can do serum protein electrophoresis, but you have to monitor these patients. If you have smoldering myeloma, treatment is very controversial, but as I told you, currently advocate treatment is close observation, but how frequently or how lately you have to do your serum protein electrophoresis, we don't know, but close observation, but no treatment is the universal call right now, but maybe in the future it might be completely changing in another 1 or 2 years itself. Right now just close observation, don't treat. Then you have plasmacytoma. Typically plasmacytoma is you treat by just local radiotherapy, that's it. Remember, in plasmacytoma, if you ask me the most common site, there are 2 types of plasmacytoma. You can have an osseous plasmacytoma and you have a extraosseous plasmacytoma. Osseous plasmacytoma typically happens in the ribs, vertebra, in all these areas, and extraosseous plasmacytoma typically happens in the upper respiratory tract, very common in the upper respiratory tract. This is the place where you are going to get an extraosseous plasmacytoma followed by the GIT. These are 2 areas where you are going to get a extraosseous plasmacytoma. Clear? So since plasmacytoma is a solid mass, many times it will present differently, like a local problem only, but typically you can treat with a simple local radiotherapy itself. That's more than enough. So fine. So now next important thing is we have to discuss on the Waldenstrom's macroglobulinemia, isn't it? Waldenstrom's macroglobulinemia, again remember, it's a B cell neoplasm. It's a tumor only, it's a malignancy only, but this is not made of plasma cells, instead it's made of lymphoplasmacytic lymphocytes. These are lymphoplasmacytoid, or otherwise you can tell they resemble a lymphocyte. Typically they are going to resemble a lymphocyte, which means these are nothing but lymphoplasmacytoid lymphocytes. Clear? That's what is a Waldenstrom's macroglobulinemia, that's how it resembles. Okay. Now, what are the features? Pathophysiology. Pathophysiology wise, I told you it is NF-kappa-B driven. Here, it's 90% of the cases, this will be having MOED88 mutations. Very, very important. If you take your pattern recognition receptors, PRR chapter, and you see, I would have told this MOED88, I would have meant a word on about this Waldenstrom's macroglobulinemia. In the future, I'll be telling. I would have told there itself. MOED88 mutations are very, very, very important. 90% of the cases you see this. Typically, what is the mutation you see? Something called L265P mutations, which affects the NF-kappa B pathway again. Clear? We saw, this thing, isn't it? This pattern recognition receptors. I told you, wherever you do pattern recognition receptors, ultimately whatever TLRs, like you have TLRs, you have CLRs, all these things, except the NLRP pathway, you have TLRs, CLRs, everything, and Rig-like receptors. All these things are going to come to one common area that's called NF-kappa B activation. This you have studied. NF-kappa B activation. You can go back and see the PRR now, because I told in a nutshell, everything, once it's activated, they are going to activate the intracellular NF-kappa B, that is going to increase the pro-inflammatory cytokines. But remember, only thing that doesn't work by your NF-kappa B pathway is the NLRP. NLRP is going to activate the pro-caspase 1 to caspase. They are going to activate the caspase pathway, which is going to convert interleukin 1B to, inactive pro-interleukin 1B to interleukin 1B. So this is the pathway for NLRP. NLRP doesn't follow NF-kappa B pathway, but whereas every other single thing is going to carry the NF-kappa B pathway. Typically the TLR is dependent on an important adapter called MOED88. So that's why I'm telling you, because the MOED88 mutations, they are going to increase the NF-kappa B pathway. That is, NF-kappa B activation will be seen in these patients. And remember, this is not a feature of multiple myeloma. It's very important to know again, this is not and never a feature of a multiple myeloma. Similarly, clinical feature wise, I can tell a lot of difference are there between multiple myeloma and Waldenstrom's macroglobulinemia, but clinical feature wise, if you want to know the difference, first one, patient will not have any evidence of bone lesions. Clear? Patient will not have any evidence of bone lesions. And patients typically will have IgM M spike. M spike will be made of IgM here. But why this is very important to tell, this absence of bone lesions, why I am telling is, this point is very important, because if the patient has bone lesions, suppose let us assume if the patient has a bone lesion and the patient has an IgM M spike, actually this goes towards a multiple myeloma, or simply you can call it as a IgM myeloma. So which means by definition, you have an IgM M spike and no bone lesions, then only it goes towards Waldenstrom's macroglobulinemia. Or in other words, you should not have any much crab feature. So this only will call Waldenstrom's, and please, this is called IgM myeloma. That's why this is such an important point. No evidence of bone lesions. And other features, you might get this fatigue, and you can get anemia or any other cytopenia, leukopenia, thrombocytopenia and all. Then you can get hepatosplenomegaly, you can get lymphadenopathy. All these things are due to tumor infiltration in the respective areas. Tumor cell infiltration. So infiltration in the bone marrow can result in anemia and cytopenias. Liver and spleen may result in hepatosplenomegaly. Lymph node may result in lymphadenopathy. And again, this is a very important differentiating factor, because multiple myeloma patients do not have that much lymphadenopathy. But here, definitely, they will have lymphadenopathy. Fatigue is common between both. That's due to a lot of reasons, especially anemia. Clear? And hyperviscosity is much more common in multiple myeloma. Waldenstrom's macroglobulinemia, because it's IgM. Always I told you, IgM is the one that's going to produce severe hyperviscosity, because it's a pentameric molecule. So here it produces IgM. That's why hyperviscosity is more common with your Waldenstrom's macroglobulinemia compared to multiple myeloma, where hyperviscosity is seen approximately 15% of the patients. Hyperviscosity may have neurologic features like blurred vision, altered mental status, headache, dizziness, and all. Even they can cause stroke also, or they can have cardiopulmonary features like shortness of breath. This shortness of breath may be due to either a congestive cardiac failure, or it might be due to pulmonary infiltrates by this hyperviscous blood, because they don't move out of the pulmonary circulation, causing infiltrates within the stasis within the pulmonary circulation causing infiltrate. So this is the reason why you get cardiopulmonary symptoms, shortness of breath as well. Then they can cause something called type 1, and I told you this hyperviscosity is due to IgM. Let us see other features of IgM. Excessive elevated IgM. Then they can get your type 1 cryoglobulinemia, that is due to monoclonal immunoglobulin, not only due to IgM. Type 1 cryo is possible. They can get platelet dysfunction. Because of that, they can get mucosal bleeding, many of these patients. Then they can have IgM deposition that can result in amyloidosis and glomerulopathy. Clear? IgM deposition may result in amyloidosis. Typically, they deposit in the skin, intestine, and kidney. Skin, intestine, and the kidney, and they can also catalytically result in amyloidosis. Number 5, they can go for chronic autoimmune hemolytic anemia and peripheral neuropathy. Typically, if you ask me why you should develop autoimmune hemolytic anemia because of excessive IgM, it's not because of excessive IgM, because this is an abnormal IgM, which means this IgM may act as a autoantibody. Autoantibody. This is one of the important things that you have to know. This, I'm telling you, this is not normal IgM. This is an abnormal IgM, which can actually act as a autoantibody, which can result in what? Damaging the RBC, and it can also result in damaging the peripheral nerve, because this autoantibody can be formed against the myelin associated glycoprotein. Myelin associated glycoprotein. Clear? All these things are reasonable in a Waldenstrom's macroglobulinemia. Remember, the reason why you get this chronic autoimmune hemolytic anemia and peripheral neuropathy is due to sometimes autoantibody nature of this excessive IgM, because this is an abnormal IgM, not a normal IgM. So they might act as because structure may be different, shape may be different, so they may act as an autoantibody. So diagnosis wise, the most important thing for exams wise, if you ask me, multiple myeloma versus Waldenstrom's macroglobulinemia in a nutshell. So here the neoplastic cells are the plasma cells. Here the neoplastic cells are the lymphoplasmacytic lymphocytes. It's not plasma cells. Then they don't have this MYD88 mutation, but it's almost 90% of the cases they are positive for MYD88 mutations. Here typically very common is IgG followed by IgA. In fact, IgM is extremely rare. Here it is the monoclonal antibody, M spike is the IgM. But remember, both will have what? M spike. That is your paraprotein will be more than 3 grams per deciliter. Here you have this CRAB features. Here typically, the most important of the CRAB is the bone lesions. Here you have this bone lesions, but here you might have the CRAB features but no bone lesions. Very important point, as I told you already. There are no bone lesions here. And again, lymphadenopathy, hepatosplenomegaly are very, very rare here, but very, very common. Lymphadenopathy and hepatosplenomegaly is extremely common here. And even if you see bone marrow biopsy, in bone marrow biopsy you will see aspiration more than 10% plasma cells that are infiltrating the bone marrow. These are neoplastic plasma cells. Here also will be there are more than 10%, but it's lymphoplasmacytic lymphocytes. It's not your routine plasma cells. These are lymphoplasmacytic lymphocytes. Typically, remember, these cells are CD20 positive. Again, these lymphoplasmacytic lymphocytes are CD20 positive. Very, very important. But both can be, remember, both can be again CD38 positive and CD138 positive. But remember, it is CD20 positive, whereas plasma cell, I told you, they lose the CD20 and it is CD20 negative. Whereas this LPL cells are CD20 positive. Again, very, very important point. So what are the investigations you can do for a Waldenstrom's macroglobulinemia? Investigation wise, I'm going to do an SPEP along with SPI to find out, because it can tell you the paraprotein is more than 3 grams. It can show the M spike. At the same time, this SPI also can tell the type of immunoglobulin, that is typically going to be IgM. At the same time, they can also confirm this SPI also can confirm the monoclonal nature of the immunoglobulin. Clear? All these things are SPEP and SPase advantage. Remember, the 24-hour urine protein is not that useful because only 20% yield here. There at least third will show this bench Jones proteins. Here light chains are seen in less than 20%. So urine protein electrophores and urine protein immunofixation are not that much useful. At the same time, you can do a bone marrow biopsy. As I told you, in bone marrow aspiration and bone marrow biopsy, there will be increased lymphoplasmacytoid lymphocytes, more than 10% in the bone marrow. And their immunophenotyping, these cells will be CD20 positive, CD38 positive, and there might be CD138 positive. Remember, beta-2 microglobulin levels are elevated in this disease also, which is again is a very, very powerful prognostic marker even in a Waldenstrom macroglobulinemia. And again, you have something called relative serum viscosity. You can use something called relative serum viscosity to diagnose hyperviscosity. This is a very important measurement in Waldenstrom's macroglobulinemia, where you measure something called a serum viscosity and you put viscosity of water. Viscosity of water ratio. Normal is 1.8. This is a normal ratio. But when you call hyperviscosity, this is especially useful for Waldenstrom because it secretes IgM. It's going to increase the viscosity. When it is more than 5 to 6, you call it as hyperviscosity. Very important point again. That's called relative serum viscosity, where you take a ratio of serum viscosity to the viscosity of that of water. Normal is around 1.8. If it's more than 5 to 6, you can call it as hyperviscosity. And treatment wise, the most important problem in these patients is hyperviscosity. That's what the problem is. But remember, here you can write as a difference also. Here hyperviscosity is a very important problem because of the IgM. But higher hyperviscosity is generally rare. You get it, but not that common. Hyperviscosity. Hyperviscosity are going to do plasma exchange. As I already told you, plasmapheresis is the most important. Then for symptomatic patients, you can use rituximab because these are CD20 positive cells. You remember multiple myeloma, I never opened my mouth on rituximab because they are CD20 negative cells. You can't use rituximab there. But here, yes, you can use rituximab. Plus or minus, you can use strong chemotherapy, the alkylating agents like bendamustine or cyclophosphamide. And you can use one more drug called, alternatively, you can use ibrutinib. Along with that, you can use rituximab. This is also one of the currently approved therapy. NEGM 2016 mentioned this ibrutinib with rituximab combination. Please do understand where is that. I have told you this MYD mutations are one of the main reasons for developing this Waldenstrom. So ibrutinib blocks the MYD88 pathway. This MYD88 pathway responds very nicely to ibrutinib. Very, very important. But before giving ibrutinib, I told you, even though MYD88 mutations are common, 90% only show, which means you have to confirm the MYD88 mutation before starting ibrutinib. Very important point again. But definitely, if it's MYD88 mutation, they will definitely respond to ibrutinib. High response rate is there, and it's proven by many trials as well. So with this, we are completing the Waldenstrom's macroglobulinemia, and we can push on to some other important things. Maybe it will take hardly another 10 minutes. One is called immunoglobulin heavy chain deposition disease, or simply you can write as IgH deposition disease or immunoglobulin heavy chain disease. So there are 3 types of immunoglobulin heavy chain disease. This is also clonal B cell proliferation disorder. This is also clonal B cell proliferation disorder, where they secrete only heavy chain. Only immunoglobulins heavy chain without any light chain. I told you in multiple myeloma, they will secrete heavy chain and light chains, or only light chains, but they don't secrete only heavy chains. But this disorder are going to, and they are not neoplasms of plasma cells. These are neoplasms of B cells, not plasma cells. So where they secrete only heavy chains. Clinical features wise, I can put a table, maybe I can put a clinical features on one side pathology on one side, and I can put some comments on it. So one, you have something called alpha heavy chain disease. This is the most common form, and the most common area that is involved will be the GAT. GAT is the most common area that will be involved here, and they usually present with malabsorption and diarrhea, malabsorption, abdominal pain and weight loss, diarrhea, chronic diarrhea, steatorrhea. This is how they present. Pathology wise, typically there will be infiltration of jejunum with plasmacytoid cells, jejunal mucosal infiltration with these neoplastic cells, and that's the reason why they typically result malabsorption, and typically these cells will be plasmacytoid cells, the infiltrating cells. Remember, this alpha heavy chain disease is also considered as a form or a type of your marginal zone lymphoma, that is MALT. You have something called an extranodal marginal zone lymphoma. Typically we also call it as a maltoma. Remember, it's a type, it's a form of extranodal marginal zone lymphoma. If this maltoma results in alpha heavy chain disease, that is going to be called as your IPSID, immunoproliferative small intestine disease, otherwise referred to as something called a Seligman disease. Seligman disease, otherwise called as a Mediterranean lymphoma. Mediterranean lymphoma. Clear? So, clear not? So, this alpha heavy chain disease, if it happens as a result of your extranodal marginal zone lymphoma, that we call it as something called an IPSID, immunoproliferative small intestinal disease, or Seligman disease, otherwise called as a Mediterranean lymphoma. So, these are some important points about alpha heavy chain disease. Then you have something called a gamma heavy chain disease. Gamma heavy chain disease doesn't contain local symptoms. Typically they have systemic symptoms. Systemic symptoms. Then they may have lymphadenopathy. Then they have hepatosplenomegaly. They have anemia, and very importantly, very rarely, but for exams it's important, they have palatal and uvular swelling. Palate and the uvula may be swollen. Palatal and uvular swelling, and this is the point that is important for exams, even though it's not that common. But remember, the alpha heavy chain disease more is going to present locally, but whereas this gamma heavy chain disease is going to present more of systemic involvement. That's how they come, like a lymphoma. Here the involved area, especially if you take the palate, lymph node or uvula, you will see one thing, that is you will see typically a polymorphic infiltration. I'm not telling PM infiltration, a polymorphic infiltrate. Pleomorphic or a polymorphic infiltrate, where you'll be seeing a lot of lymphocytes, lymphocytoid cells, plasmacytoid cells, plasma cells, everything will be infiltrating. Immunoblasts, eosinophils, a lot of things will be infiltrating. Remember, it is also referred to as something called a Franklin disease. How alpha heavy chain disease is also referred to as something called a Seligman disease or IPSID, immunoproliferative small intestinal disease. So here you can also call it as a Franklin disease. This is the other name for this particular condition. Remember, usually it is associated with a lymphoma. There I told you alpha heavy chain disease is usually associated with the maltoma, but here this is usually associated with the lymphoma. Gamma heavy chain disease. Then you have a mu heavy chain disease. Mu heavy chain disease. What is the feature of mu heavy chain disease? Typically they will resemble, the features will be extremely similar to CL and SL. That's why it's very important, because you will have fever, lymphadenopathy, B symptoms, fever, lymphadenopathy, hepatosplenomegaly, lymphocytosis. This is the typical presentation of mu heavy chain disease also. But typically in the bone marrow, you will see vacuolated plasma cells and lymphocytes. Vacuolated plasma cells and lymphocytes, and the patient will have a panhypoglobulinemia, which means there will be reduced production of immunoglobulins of all classes. Reduced immunoglobulin production. That's why I told you they will resemble CLL in many conditions. Again, infiltration of lymphocytes in the bone marrow. That's the reason. And again, idiopathic. Clear? We don't have any clear underlying cause. At the same time, how will you diagnose this heavy chain disease, immunoglobulin heavy chain disease, is by doing SPEP. And remember, almost every single SPEP will show M spike, and you're going to do a serum protein immunofixation where you're going to know the composition of the paraprotein. Composition will be made of only heavy chains. That's the key. Only heavy chains without light chains. That is the diagnostic point. So SPA is actually more important than SPEP for diagnosis of a immunoglobulin heavy chain disease, because you have to prove that these immunoglobulins that are in excess are these are the only diseases that produce this heavy chain only. Remaining everything produces both heavy chain and light chain, or like multiple myeloma patients may have only light chain, but this is the only disease that produces only heavy chain. The SPA is really important to find out the composition. But identifying the M spike alone is not important. You have to mix with SPA and find out what is the composition of the immunoglobulin. Treatment wise, remember, treatment is actually quite difficult. And one more thing I didn't tell you, this alpha heavy chain disease, to be honest, is going to have association with Campylobacter jejuni. Why I am telling you, will understand in some time. It's associated with Campylobacter jejuni. Why this is important? Because your treatment is based on antibiotics. Initial cases, only antibiotics is enough. Just antibiotics. But late stages, you need chemotherapy. You need chemotherapy depending on tumor cell marker CD, what CD it's representing. Depending on that, you can use the chemotherapy. But other two diseases, I'm going to use only chemo. That's it. Again, chemo depends on what markers they express. But only in early stages of this alpha heavy chain disease, I can try antibiotics because it is Campylobacter jejuni associated. That's why I told that point. Okay. Final one is the POEMS syndrome. We are reaching the terminal area. Last one, that's the POEMS syndrome. So POEMS syndrome stands for something called polyneuropathy. O stands for organomegaly. And E stands for endocrinopathy, and M stands for monoclonal protein, and S is going to stand for skin changes. Clear? So in this, if they ask you which of the thing which is mandatory for diagnosis, which is 100% seen, one is polyneuropathy and second is monoclonal gammopathy. So this is typically seen in 100% of the cases, which means these are the two crux of the POEMS syndrome, which means without these two things you cannot diagnose a POEMS syndrome. And very importantly, they can have bone lesions where they, instead of having lytic lesion, they have osteosclerosis. That's why this is also referred to as something called an osteosclerotic myeloma. They may not have a lytic lesion, instead they will have a osteosclerosis. This is a very important point. That's why this POEMS syndrome is otherwise referred to as something called a osteosclerotic myeloma. Very, very important point. Clear? And typically the criteria for diagnosis, you have three criteria. One is called mandatory criteria, which means it should fulfill, and both these are needed. I told you already, one is this polyneuropathy and second one is this monoclonal gammopathy. Monoclonal elevation of hemoglobin, which means you will have an M spike in the SPEP, and you can do SPA to find out what is the M spike component. And second, you have major criteria. I will tell three major criteria. Both are needed for mandatory, and at least one out of three major criteria is needed. What are the major criteria? One, sclerotic bone lesions. I already told you it's an osteosclerotic myeloma. Second one, patient may have a Castleman disease. I didn't tell you about that. We'll discuss later on. Castleman disease, that's also a major criteria. Third one, the patient will have elevated VEGF levels. And this is the PGI question, I think in 2017 maybe. So POEMS syndrome will have elevated VEGF levels. It's one of the criteria also for diagnosis. Then you have minor criteria. Minor criteria, you have organomegaly. Any organomegaly, typically hepatosplenomegaly or lymphadenopathy. That's what I'm talking about. Then they have extravascular volume overload. I think again third space collection. You can simply write third space collection or extravascular volume overload, like pleural effusion, edema, third space collection or edema, pleural effusion, ascites, edema, all these things will be there usually. And next thing, they will have endocrinopathy. It can be adrenal, thyroid, gonads, any endocrinopathy. Then they have skin changes. Poems, S stands for skin, because these three we are not given the major or mandatory criteria because this is less common. Skin changes can be hypertrichosis, hyperpigmentation, anything. So skin changes, very commonly what they will be expecting is this hypertrichosis and hyperpigmentation only. They can have flushing, acrosinus and all, but hypertrichosis and hyperpigmentation are very important for exams. Then you have papilledema. Then you can have thrombocytosis or polycythemia. RBCs or the platelet levels may be increased. So 1 out of 6 minor criteria must be matching. So 2 mandatory, 1 major, 1 minor. 2 plus 1 plus 1 is going to give you the diagnosis of poems. Clear? So this is the diagnosis for, this is the criteria for diagnosing a poem syndrome. I think this is an exhaustive coverage. So each and everything is important, whatever I told you. The most important is the differentiation table. So please look back again once again. The differentiation table, between the various variants of multiple myeloma, and I put a differentiation with the Waldenstrom's macroglobulinemia also. So please do understand that, and please study the table as much as possible and go for the exam, because that is the key element of this 1.5 hours lecture. And anyways, we are completing the plasma cell dyscrasias. In the next lecture, probably we'll be moving on to the leukemias.